virtually this morning. The meeting is being recorded, and a copy of the recording will be available on the website later following the conclusion of the meeting. Can I offer a very warm welcome to two new members of the board this morning. Firstly, to Councillor Rhys Good, who is our new independent member, local authority, who is attending his first public meeting today since his appointment commencing on the 1st of January. Well, Rhys, good to see you. Very warm welcome. And also a very warm welcome to Dr. Sarah Medlicott, our new associate board member, who is also attending her first meeting today. Sarah is a current locum GP at Bronigarn, having left Bronigarn in December, but has returned very quickly. So, Sarah, really good to see you as well this morning, and thanks for joining your first board meeting. Just a couple of other welcomes this morning. As usual, we have our shared listening and learning story, and for that item, it's terrific to welcome Robert and Gemma Cummings, who are here to present that item, alongside Natasha Davis, Donna Selden, and Abe Sampson from our charity. So good to see all of you this morning, and we'll come back to that in a moment, but a really exciting, brilliant innovation that we've seen at PCH. So we'll come back to that in a second. Before I do that, can I also welcome Owen James, Head of Corporate Finance, and I think Mark Jones from Audit Wales, also going to be joining us this morning online for item 5.1. And as usual, there are a couple of others. Patsy is joining online, so is Lisa Curtis-Jones, and we've not received any apologies for absence. And of course, Simon is also online, having got stuck in traffic this morning. So yeah, we've got more people online than usual, but needs must and all of that. So before we get to the first main item, which is the shared listening and learning exercise, can I just say to colleagues who are presenting reports this morning, please take into account that the board will have read the papers, and if you can draw attention to any key points that you wish to flag in this morning's meeting, that would be very helpful. I am looking for us to take a short break at around 10:30, so factor that into this morning's proceedings. I don't believe there are any declarations of interest. None have been declared in advance of the meeting, but if there are any that colleagues need to raise, please do so now. No, thank you very much. Item 2, the consent agenda. There are a number of things listed towards the back end of today's meeting, but if there are any matters that colleagues would like to see brought forward, could you let me know now? Are you content to leave them all there? Yep, okay, splendid, thank you very much. I am going to move the agenda around slightly, so to bring the shared listening and learning story forward. So on that basis, I'm going to hand over to the team. So I don't know, Natasha, are you starting first? Or
no,
Rob, Gemma?
Start.
Rob, Gemma, terrific to see you. And can I just say, it was a real pleasure to be with you at PCH with Ellis. Ellis stole the show, of course, in the opening of the immersive room. But it really is fantastic to see you here this morning to talk about this brilliant innovation and what our plans might be, hopefully, for the future. So over to you. Thank you.
First of all, thank you very much for inviting us today to share our story on the Ellis Cummings appeal. So just a little bit about Ellis. This is Ellis. He's 7 years old. When he was 3, he was diagnosed with autism. He's the youngest of 4 boisterous rugby playing brothers. Ellis attends a special school, is completely non-verbal. He relies on me and Robert for all of his personal care. He's very sensory driven and becomes very overwhelmed when he is put into new places. If there's any new sights, sounds, smells, it can very often send him into a bit of a sensory overload. Next slide, please. This is particularly relevant when we attend medical appointments. They're always very challenging, and emergency care is pretty much impossible with Ellis. He suffers from sensory overload, as I just mentioned, and will go into severe meltdowns. We've attended the A&E department on quite a few occasions, unfortunately, throughout Ellis's 7 years. And after one particularly challenging visit where we couldn't administer any emergency care, I was in tears, he was in complete meltdown. Robert, I think, wanted to book a one-way ticket somewhere. The staff, everyone was just helpless to help, and you could just tell, you know, the desperation and with all of us. And we realised that we needed to try and do something to help children like Ellis and their families and carers when they attend, especially wanting emergency care. Please. So after a well-deserved glass of wine, we decided to set up a GoFundMe page. Our original hope was just a few £100 to buy some bubble lamps, some sensory equipment, some anything that would distract a child that needed emergency care. And to our absolute astonishment, overnight we hit our goal, and in the days and weeks to follow, we doubled and then tripled our initial ask. Our local community were completely amazing and were instrumental in raising these funds. So many groups contact us, local businesses, donations. We ran quite a few charitable events, didn't we? And before we knew it, we were making quite a lot of money from the appeal. And in 1 year, we raised £13,000. At that point, we knew that we could do something very serious with that. And we spoke to a paediatric consultant in Prince Charles A&E and identified a space that we could use for this sensory kind of area. We attended Ellis's special school because we thought they were the experts in seeing what works with children with ASD and any other not neurotypical children. And we set our sights on an immersive room. So that was what we were aiming for. And that is when we contacted CTM Charitable Funds, and together with Abe and the team, and working with the Prince Charles General Hospital manager, we managed to get everything together, and we're very pleased to announce that that immersive room opened early December. Next slide, please, then. We've had so much public feedback following the opening. So many people have reached out to us on social media. I know it was quite heavily covered in the media. So many people contacted us from that, and it's completely blown us away with the feedback, and to know that we have made that much difference. I think for us, what was always the biggest worry was children like Ellis and their carers. You're almost at a crossroads where you've got to make the decision between, is my child's medical problem going to outweigh the emotional distress it's going to cause them? And for any parent, that shouldn't be a deciding factor in getting emergency care for your children. And it just worries me how many children have gone without care that they really do need because it's just too hard to bring them in. So to know this has made a difference is, yeah, it's all we've ever wanted and more. If you want to.
No, it's been absolutely. It's been great to see, and like I said, the feedback has been phenomenal. It's been great, and we've visited A&E with Ellis Hill and using the immersive room, and it's helped him and us as a family so much, and it's going to help so many other children as well and families. And a little example as well, I took Ellis to YCC to an orthopaedic appointment. The appointment was running late. It was 30 minutes, understandable, very busy. But then 30 minutes to us was a lifetime. Ellis was just throwing things, biting, running around because of this clinical environment he's not used to. So stuff like this would have helped in that environment as well. So not just the A&E department, but all multidisciplinary departments that can help all appointments.
Yeah.
So
just go to the next slide, Emma. As you can see, this was on the day of the opening. He has become a bit of a diva, and we have had our negotiation of custard creams in payment. But yeah, so Natasha.
thank you.
Thank you very much. Thanks. So about the musical chairs here.
Yeah. So morning, I'm Tash. I'll speak more slightly from the clinical side of it. I'm one of the managers in PTD up at PCH. Basically, I mean, I think generally numbers of children with additional learning needs, they're just skyrocketing really. But also, it's not just the kids who are neurodiverse, it's the ones with additional learning needs. It could be a child who's had a traumatic experience in ED, just generally being scared. It's scary being an adult in ED and being unwell, let alone if you're, 4, 5, 6, or even 15. Do you know what I mean? So it just helps to provide an environment that's just safe and appropriate, but particularly for those with additional learning needs. The numbers, I mean, even I was on a clinical day yesterday, and I'd probably say we didn't have many patients yesterday, but a quarter of the patients had additional learning needs. In fact, one child arrived immediately and the parents said, "Is the sensory room free?" Literally, they were just through the doors and they literally were able to go straight into it. So, as you can probably imagine, obtaining simple observations like just oxygen saturations, heart rate, a doctor, or even doing a temperature in an ear, these things can take such a large amount of time. The child is stressed, which then obviously knocks on the parent is stressed. They come in for anything from simple illnesses like fevers, your rashes, to more serious injuries, which then obviously require more time. They're in the department for longer. It can be incredibly challenging. And as Gemma and Rob said, this environment is something that's really familiar to them. It's often in nearly all of the special needs schools. So not only is it calming, but it's actually an environment they're really used to. So they can just sort of settle in almost immediately. And as we know, a calm and cooperative child equals a calm and happier parent or carer, which actually then has a knock-on to happier staff, because the staff just feel like they're able to provide care that's completely appropriate for that child. They love showing it off, and they love when they see the clinical benefit of, like, this one is one where you step on the letters, the one that's in the little illustration there. It allows us to do almost an immediate assessment of someone's lower limb injury, because, they come in and they're just sort of dancing on things or popping things. It actually allows to be sort of part of the examination itself, not only in an amazing environment. So I think I know clinically it's for the children. However, the effect on the staff cannot be underestimated. And I think all the evidence and all the research tells us that if you have happier staff, you're providing better quality care and you will get safer care every time. So whilst I appreciate it's for the children, the staff in ED, the adult and paediatric staff, the cleaners that come through, just everybody, all they do sometimes is just look in and then they just carry on walking, and they do so with a smile. Or sometimes if it's quiet, we all pop in there and just have a bit of fun, because I think, working in the NHS is hard, and I think any opportunity we have just to have a little moment to decompress is lovely. So I won't read those out, but basically the staff have loved it, and they sort of feel so grateful that we've been able to invest in such a piece of kit. Like Gemma and Rob said, when Rob came down and explained the plan, we all just imagined a bag of lights, maybe like a bubble lamp, maybe some fidget toys, maybe, just a little bag that we could take into a cubicle and give to the children. And we've just ended up with so much more than that. So we're so grateful, primarily to Rob and Gemma, and obviously the charitable foundation that matched their amazing fundraising. So yeah, I can't say enough thanks to how much the effect is immeasurable. Literally, I don't want to overstate the point, but it really is, mostly for the children. I'll just do a couple of points with the plans going forward, and then I think Abe will take over. The plans, there's so many different programs. You can either just watch things. There's some 360-degree videos where there's just like a camera, I guess, just sat up at a bus station or a tube station, and you just watch life going by. So some children with additional learning needs who have special interests, they can just literally sit at the train station and trains are coming by. All those ones where you interact, and they're all very seasonal. So we had some Christmas ones, and then there's obviously a fireworks night. There's all sorts of things. But the idea also is to maybe make some bespoke content, particularly for children who maybe have to go to theatre or for a CT scan. I don't know as an adult if you've ever had to have a CT scan or an MRI scan. They're quite terrifying. So if we can make a video that sort of follows the route of the child to these areas of the hospital, it will hopefully at least lessen. They can at least just experience the journey initially before actually going there physically. And then our initial plan, which was to get bags or a bucket of things that we can take into the cubicles, because as I mentioned, the numbers that we're seeing are huge. So actually, often we have more children with additional learning needs than will fit in the cubicle. Sometimes they love to share and the families are so generous. They're just like, yeah, come in, we'll all play in here, if it's nothing infectious, obviously. But sometimes there's just too many children, so some have to stay in their own cubicles, but we can give them small things. So the idea is that we're going to try and get some buckets of things that then we can just take in, so that when there's too many to have in the room, they can, they can have their sort of bag of things. So
Thanks.
Well, I'm Abe Sampson, the head of charity for CTM. So just quickly touch on, I think, some of the learning from this project and what we like to do going forward. I think it's been a massive example of the potential of community fundraisers to inspire change and to make a difference. And I think it's very important that our charity is there to help support other fundraisers as well, who have ideas as well, and projects like Rob and Gemma, and support them in terms of coming forward and looking to, if they're looking to fundraise, if they have ideas. I think it's really important that we learn from that potential and the difference that they've made. So that's one really important element. It's very early in terms of obviously the project, the room launching in December, but I think already the feedback has been very overwhelmingly positive, and I think that's something that again that we're trying to learn from. We've already had a number of different organisations, different community groups, charities, other health boards reach out as well to ask about the impact of the room and to look at carrying that forwards and also look at opportunities across our other sites and across other services as well. So that's one thing that we're keen to explore is look at the impact the room's making, but how can we then look to support projects like this through the charity across CTM. And crucially, I think one thing not to lose sight of is that the success of this project, as well as the foundation that is rooted in Rob and Gemma's involvement right from the start and driving that forwards, helping to co-design, co-develop the project. And that's something that again we will replicate for other charity projects as well. As how do we take that model forwards and learn from that. So again, it's looking at what are the applications for this technology, but also what is the learning from just how this project came together and what made it a success. So again, that's something that we're really keen to build on. And as I said, there's been a lot of interest, a lot of feedback so far. So yeah, that's something that we're really keen to build on. But there's lots of opportunities already that are emerging just as a result of launching over the last 6 weeks. So
thanks, Abe. Thank you all very much for that presentation. And if you haven't had the chance to see it yet, I do recommend a visit. I mean, not all in one go because you won't all get the rest, but it is well worth seeing it. It's terrific.
It's always use.
I did joke that perhaps some of the staff might find themselves in there just playing with it because it's so amazing to see. Right, any questions or Richard? Thanks.
Yeah, absolutely amazing. I think there's a couple of points. So I think the co-production thing you mentioned there, absolutely. And it's so difficult to do that. If you look at true co-production, it's really hard to do. But this is evidence as to how it can work and benefit. And I think then it adds into how sustainable the initiative might be once it's been co-produced and rooted. I think what I was taken away is, and I think you picked up on it, these environments are so noisy and busy. And as a nurse in this organisation, sometimes the sorts of things that are really important to you as a family are really difficult for me to identify and to focus and prioritise. And so absolutely taking this type of initiative and doing it in the way that you've done it, I think lends itself then to opening our eyes and allowing us to pause for a moment that actually the impact here is significant. And we need to then think about how does this work for the organisation? What do we do with this that may benefit others, clearly with children, but actually does it benefit other fields within the clinical setting? And I think one of the things I'd like to think about going forward, so there's lots of research that sits behind this around what sensory can do for children and adults with autism and sensory deprivation, or deficit rather. But actually, is there something more local that we can do in and around the research element? How is it impacting positively our local population, and what does it mean to them? So I think there are opportunities in that to strengthen as well what you're already doing. But outstanding. Thank you very much.
Gethin, and then Carolyn and Reese. Okay, Gethin.
So Gemma, Rob, thank you for coming to tell that story. And it's been lovely to be heard of its development over the months. So it is brilliant. And I guess the impact it's had is massive, and as Tabs just described, the impact on how the ED functions. I guess the question really, probably looking aimed to you and Donna, and how do we then use that evidence base now to look at, because of course we've got 3 paediatric EDs, and it's brilliant we've got it in Prince Charles, but we now need to think about Morgan and the Princess of Wales EDs and how we make sure we've got that, but also recognising that through a number of our hospitals we also operate on both children and adults who've got learning development challenges, and how do we create some of those environments in other areas that are really, really stressful, particularly thinking about the operating theatre environment and allowing those patients who have those additional to be managed in a way. Interestingly, we probably do most of our operating in Prince Charles on patients with those additional needs, and I think it's how do we look at that across, and then I'm also then thinking about from a dementia perspective and other things, that broader key. So I guess there's something about how we look at making some of our environments as therapeutic as we possibly can, as part of that. But brilliant, thank you.
That's good. Karen.
Yeah, I sort of covered some of things I would say. Thank you. I mean, it's just absolutely heartwarming, isn't it, to see something where a need has been identified, people have really pulled together and produced something so brilliant as this. I think the evaluation of it and the understanding the impact is really, really important, because sometimes we do these things and we know they all work brilliantly, but then how do we spread that? How do we make that work in other areas? How can we demonstrate effectively the impact of that? So I think a sort of link with research and evaluation about what does it mean. But the other thing that struck me was you were saying about CT scans and MRIs and things, how everybody's terrified of these things really, and how terrifying it is for everybody in ED, and just how, a bit like Gethin was saying, how we translate the learning from this to say, well, actually, can we make, when we're designing new areas, how can we take into account things that everybody would benefit from? And some of these special, I know you can't all have a room like that for everybody, but do you know what I mean? Just taking some principles of that and thinking, well, actually, when we're designing new areas, we can learn from this and say, if we included some of this in every area, everybody benefits from that. And for people with very specific needs like dementia and these sort of cases, we do design something especially for them. But it just feels like there's such a lot of learning in that, because a lot of people that haven't experienced just wouldn't have thought of these things, wouldn't I wouldn't have sort of thought that's something we really need. But having heard you talk about it and seen it, you just think, wow, that has made such an impact. So yeah, thank you very much. Really, really interesting.
Thanks, Karen. Reese.
Thanks, Chair. Thank you both for coming in and telling the story. It's really amazing. As someone who's inherited a child with additional needs, I can already see how amazing that would be, just to make life easier, like 100%, like reducing your anxiety, let alone anything else. But I think what I've taken away from this, and I think it's really interesting that you were talking about sort of having those bespoke videos of how you get from one part of the hospital to another, perhaps. But I think that the thing that really strikes me is how do we get this rolled out across the entire CTM footprint, because this stuff could help so much, but at so many cheaper, lower level elements as well. I mean, one of the things we lean on a lot at home is using AI to create social stories for just normal everyday things where you're like, oh, he's going to kick off. If we've just got this printed out, it could make life 10 times easier. And I think what we need to look at with the charities, how do we take advantage of those sort of cheap alternatives while we look for that higher level of funding to roll out these sort of rooms across the estate. So I think anything that we can do about that to roll that out quicker at a sort of lower cost level, to make it available to all clinical staff, that if they do have someone, whichever department it is, that if it is a bag of things, if it is just a bit of software where you can quickly create a sort of bespoke social story, I think that could be really transformative, because you don't always need that room, that immersive space, but you could do with that little bit of help. So anything we can do to speed that up, I think would be really, really welcome. And thank you again for coming in and speaking to us.
Thanks, Chris. Philip and then Paul.
Just really quickly, just really echoing Carolyn's points around learning from the principles of this. We've been doing a lot of work with veterans recently, and I think a lot of the principles carry across in terms of individuals with complex PTSD, for example, finding those clinical challenges to people. Obviously, as a health board, we're keen to move care closer to people's homes. That obviously leaves us with an estate. And when we look at how we're going to use that in the future, how do we design it so that they're nice places to come to, whilst still encouraging people to access care close to home? How do we draw on those principles to make it fit for the person?
Yeah, like others have said, really, really amazing story. And I think, as Reece just said, it also highlights it's like the whole pathway, isn't it, for the people? So yes, this is about the physical environment people come to the ED, but what about the whole experience pre-ED or pre-operation or pre-outpatient appointment or scan? So I'm just thinking, Rich, maybe there's a bit of work we could do, taking some of the learning from this process in terms of a user experience or people's experience group. I'm ashamed to say I can't quite remember if we've got a children and young people's reference group. Jenny's going to put her hand in and say we have.
Sorry, just to say, as a result of all the work that Robert and Gemma have done, and also Nicky Mulane, there is a charity that you've linked into in the Regent area that are posted into the community. It was by chance I saw a Facebook picture on Facebook. So they're a charity that's linked in with MacArthur Glen, the Pounds, and they have created a sensory bag. So it's their first link with them, and myself and Abe have met with them. So they want to work with us as well. We've explained the work that Robert and Gemma have done, so we're going to look at setting a working group up across a number of different specialties and care groups. But hopefully they will be dropping a sensory bag down to me tomorrow. So I'll be able to pick that up and see. So in relation to that, there may be some quick wins that we can get from that perspective as well.
Thanks.
And just thinking in on that, just to say that that charity has a well-established network of families as well, with parents of children with a variety of different additional learning needs. And so there's a really great learning opportunity there as well that we want to explore in terms of what is the feedback and what is the experience across our sites and how can we work with that.
And I was just thinking about even just things like placing information, the way we send letters out to people. There's a lot of learning, and if we've got some families we can test things with and say, well, how would this land with you, or what would you think would be better? What could you? And Reece talked about using technology to help that. I'm just thinking there's a whole opportunity to the whole pathway of different people's experience in different parts of our service, and helping our staff also understand this, because our staff have to understand the particular needs that people have. So maybe we can pick up a broader thing. Rich.
Thanks. Simon and then Helen. Thank you.
Thank you, Chair. Thank you, Rob and Gemma and everyone. I'm really sorry I'm not there to hear this in person. I was really hoping to be. I just wanted to say, I think this is an indication of the maturing of our charity as well. So with Abe now in place, we've got the expertise and capacity to kind of take these opportunities, working with families like this, and then have the time, expertise to turn that opportunity into a plan, and that plan then into reality. So I think this is for me is also a story about where the charity has come from and where it's going, and also the ability then to take these things, and as Abe has kind of mentioned and Jenny's mentioned, the ability to take that learning and apply it to other parts of the health board is fantastic. And the doors these things open through the positive publicity that are received for things like this, is fantastic. And every good story opens a door, and all those doors then open up the opportunity to do more, to help more people in these kind of situations. So yeah, it's a really positive, really good story, and I think it's a lot here about where we're going in the future as well.
Thanks, Simon. Helen.
Thanks very much. Yeah, I echo what everyone has said. Thank you for coming to share the story. And it really feels like the scales have fallen from our eyes, really. You've shown us that something that you make a small difference can have a huge impact. But as a board, I'd like to know how we think that we can keep our eyes on this, because it's really powerful for you to come and tell us these things. And that's great. but we don't just want you to go away and nothing happen, and you see nothing happen. So I'd like some assurance that we know that we will know what progress is in looking at the spread across the organisation over time. Clearly, that will be limited by money in some respect, but we need to make sure that we can optimise what we can do in respect of this. So some assurances around that, really, that we keep our eyes on this.
Thanks, Rich. I think there's probably a role here for Quality, Safety, Education, Experience Committee, isn't there?
Absolutely, and I think so. We've got an established People's Experience Forum, of which children and families are active participants. I think maybe what we need to consider how that becomes a focus throughout the financial year or calendar year, even set various points so we can update as to the progress around the sensory projects and the things that are happening in the space. So I think we can absolutely do that.
Yes. Dom.
Just thank you. That's really amazing. I'm not going to echo everything I've said here, but very much felt. Just in terms of cross-linking it to other things we're doing, we have got quite a lot of virtual headset use in our intensive care units. And again, that's an area that we're really exploring. We've shown psychological impact from that. So I think that's another string to the bow that we pull into all this, because virtual headset can tell you where you get across the different sides of things. So it's just trying to link all the things we're doing in the different areas into one package, I think would make such a difference.
Thank you very much. Lauren.
Sorry, just very
Okay.
quickly.
No, it's really important, and I think, you know, for those who might have read the chair's report under item 4 or 3, yes, innovation and creativity. This is exactly where we should be. I mean, yeah, we have seen in the past 12 months some amazing examples of how innovation and creativity is the heart of what this organisation is about, along with passion and compassion. So, you know, this is a great area where we know we're having an impact in the lives of people who will find these experiences of coming into hospital so dreadful. So yeah, don't apologise for asking a question.
Just to flag that we've got an opportunity to tap into expertise that we've already got in the health board, haven't we? So think about the occupational therapists, absolutely skilled in terms of sensory development and needs and opportunities, speech and language therapists in terms of how we can support people to understand what's happening around their non-verbal. So yeah, we can link in there and make sure that we tap into that specialist expertise to help shape where we get to.
Excellent, much appreciated. Thank you. Okay, thank you very much for being with us this morning and for sharing, you know, all of the work that you've done, the drive, the enthusiasm, the determination to deliver this, but then the scope and opportunity for this to be rolled out elsewhere, I think is absolutely wonderful. So thank you all very much indeed for being with us. Thank you. Okay, we'll move back to item 3, the board's action log. Just there for noting, there are a couple of matters proposed for closure. Any questions or queries on the action log? Are you happy to close those items that are listed? Yep, thank you very much. Item 3.2, matters arising not contained with the action log. I don't think there's anything that is falling out of that that's not already covered on the agenda. I'll move on to item 3.3, the chair's report and the affixing the common seal. Just a couple of things to flag in my report. You'll see at the back end of the report, we've got the letter from the Cabinet Secretary following our public accountability meeting, and then my response to him, responding to those things that he outlined in his letter to us. So one of the things I've covered in my report, which we've reflected in the response to the Cabinet Secretary, is the way in which board remains focused and gets assurance in terms of some of those key performance, you know, challenges. One of the things he's been asking health board chairs in the course of the public accountability meeting process has been around how we remain focused on the key challenges, how the board can be assured about progress. And obviously we have a huge amount of information which comes to our public board, not just in terms of the pack of data on performance, but the range of other matters that we discussed that are linked to our strategic direction as an organisation, but how we are then also meeting those targets that are set by government. And what I've said in response is that there will be a number of things that I want us to look at in the course of this year in respect of our own board development. Our board agenda, as you know, is heavily focused towards secondary care, because that's where most of the measurements are. As a consequence of that, we do spend a lot of time looking at how we're meeting targets, what the challenges are, how we're reporting those to government, how we're investing in changes that allow us to be better at meeting those targets. The problem is that we don't spend nearly enough time talking about the sorts of challenges and opportunities in primary care and community care, despite the fact that as a board, chaired by Paul and driven by others, we are seeing a huge amount of work being done in that primary community care space. So we've got to find a way, and I've talked to Paul and to Claire about this, as to how the board agenda during the course of this year can be reshaped to incorporate a greater degree of focus by the board on primary and community care. So that's number one. Number two, I think it would be useful for us as we look at our performance data and the targets and the challenges we face to try and elevate some of that and draw out of that complexity of data, perhaps 3 or 4 key challenges that we want to focus on in each board meeting, so that we are looking specifically at some of those key challenged areas. I'm conscious there's a lot of information that we put in front of the board to digest, and I'd like to find a way of perhaps elevating some of that, bringing some of that out to allow the board to focus more acutely on perhaps some key challenges in our public board meetings. I'm also going to use our board development sessions in a way that links directly back to our board assurance framework and our risk register, so that we're focusing again on those areas where we know we've got some of the greatest risks to respond to. And Gareth, Callie, Emma and the team have been doing some really thoughtful work around that. We've got a board development session in February. The plan is to pull all of this together with you in that board development session, so that we can be collectively a bit clearer on what would help us as a board over the next 12 months, as we drive that assurance piece, but not just drive the assurance piece, but remain focused on those key strategic areas. I've said in here about creativity and innovation, and I mean that. There are huge, amazing examples in this organisation strategically in terms of the work that we're doing around primary care, community care, digital and data, the work we're doing around developing a clinical services plan, how we are ensuring that we are meeting the objectives set out in CTM 2030, how we're doing smaller scale innovation in our different sites. And I think that's something we should celebrate, but something that I know the board will want to deliver on in the course of the year. So I've touched on some of that in my response back to the Cabinet Secretary, but I'll be updating him on that when I have my end year review on the 16th of March. It's not quite the end of the year, but it's almost the end of the financial year. So the report's there for noting. I'm happy to take any questions or points on the report and on the Cabinet Secretary's letter, or indeed on my response to the House. Yeah, Richie?
Yeah, thanks. So just on that point in relation to community and primary care, so I know colleagues around the table will talk to articulately around the fact that we are seeking to move services closer to home for our patients and communities. But I think the point I really wanted to raise around this is my wholehearted support around that, in that some of our most vulnerable patients in need, and actually some of our sickest patients are in the community setting, particularly with long-term chronic conditions requiring that care. So that elevated focus and attention from board certainly would be welcomed.
Thank you.
And I'd be remiss if I didn't say we are hammered. We have intense scrutiny with regards to our acute services, but we've got a duty for the whole population, and that is based on prevention and addressing the wider maternity health as well. So bringing that forward.
Any other questions or comments? Colleagues, happy to note the report, and can I ask you if you can just confirm the use of the common seal under item 3.1? No, thank you very much indeed. Okay. Chief Executive Report. Thank you, Paul.
Thanks, John. So in my report, as a regular item, I update on the escalation status of the organisation, and you'll see there that we received notification in early January that we remain in targeted intervention, urgent and emergency care, and enhanced monitoring for palliative care and cancer. I think given some of the recent improvement in our elective care position and cancer performance, we would be hopeful that that status will soon be reviewed and hopefully de-escalated. And similarly, there have been some good improvements in urgent and emergency care over the past few months. Obviously, as I touched on later on the report, the recent post-Christmas New Year period has been pretty challenging for us and put a real pressure on our urgent and emergency care system. But just to, I think, recognise the big improvement we've seen in ambulance handling over the past months. Yes, there have been a few days recently where that's been more challenging, but overall our trend in that area has been to improve. There is still further work we know we need to do on that, as well as reducing the time people are waiting in the emergency department for care and bed in the hospital. So we continue to monitor it. I think Welsh Government are also in the process of just reviewing the escalation framework again, just to sort of look at the criteria by which they are assessing organisations. So that may well change as well moving forward. Also, just to remind people, a few months ago we talked here about in a briefing actually about the opportunity of developing our estate and potentially working with a partner to help develop our estate. Sally and I have been having conversations about that, and what we've agreed we're going to do to start with is do a bit of a baseline on our current estate across CTM. We've got the technical estates information, you know, in terms of the state of the buildings and all that sort of technical assessments. But there are quite a lot of buildings that we've got as an organisation that I think we need to have some conversations about, particularly in light of our ambitions around moving services close to people's own homes, et cetera, et cetera. So we're going to do a baseline of what we've got, and we'll bring that back to board so everybody can see what we have. We are gradually making steps in our estate. We've just disposed of. Yeah, sorry, shaking your head.
No, some money hasn't arrived, I suppose.
Oh, the transfer of the Pontypridd Health Centre. Yeah. But I thought I'd signed the.
It is all signed,
transfer
but
documents.
unfortunately, the cash has not.
Yes, arrived. Okay, well, we haven't completed yet. Hopefully, that one will complete soon. And obviously, we've got the land swap arrangements in Bridgend around the development of the Bridgend Health and Wellbeing Centre and the disposal thereof of 3 community clinics that was always part of that arrangement. So, you know, we are making progress, but I think there is further work to do on the estate. But I think we need to get our understanding of what we've got first, and then we can start to make some decisions about what we do moving forward on that. A couple of people-related issues just to also update on. So, you noticed in my report progress around the Band 2-3 support worker role. There's been a job description agreed nationally now, and an expectation that all health boards will move towards that piece of work to assess which Band 2 workers currently should be re-banded as a Band 3. There's quite a bit of work to do for us on that, because it means we've got to assess the 1,300 healthcare support workers we have across the organisation to understand individually what their tasks are and what they have been doing. And that's going to require quite a bit of work from the clinical teams involved, and ward managers, team managers and others in that. So that is going to be a big undertaking, and understanding the financial implications of that, obviously the financial implications depend on how many people will be falling into that category. You'll remember that Welsh Government have agreed to fund that uplift for this year, but moving forward into next financial year, that will have to be picked up by us through our own allocations. So that is going to be a financial challenge for us moving forward. Similarly, you'll know that we had a conversation in December about the shift patterns, just to say that that process is now about to move into formal collective consultation with the trade unions about the original proposal for the shift patterns, and now some revisions to that process, given the feedback we've had from staff and from unions, and that will run through to the end of February. And then we'll then need to obviously individually consult with members of staff about the impact of the shift pattern change through the summer. Again, this is a big change and a big consultation process that we're going to have to go through with clinical teams. But obviously it's really important to get this right. I don't know how if you.
No, just going to remind board members really that there will be a touch point back to board as well at the end of March, just in relation to the outcome of that collective consultation period prior to any implementation, and so back and forward at the end of March.
Yeah. There's a similar vein around workforce. I noticed in my report there, the Unite Union has recently been balloting the health visitors in CTM about the opportunity for industrial action, about dispute around the banding of their role. Currently, health visitors are band 6. Historically, in old CT, back about 10 years ago, Ponty and Rhondda even trust some of our health visitors were actually banded at band 7. When there was a national profile for health visiting at band 6 put in place, those members of staff were moved to a band 6, but on protection for 10 years. That protection period is now ended. So there is a bit of a dispute, and that's why it's particularly our organisation that has this particular challenge at the moment. However, obviously the role description for a health visitor is a national profile. So we're trying to work with Welsh Government colleagues and NHS employers to see if we can get a revised national job description agreed. It is made more complicated by the fact that the NMC have recently changed the educational level for health visitors and school nurses from a level 6 to a level 7 into the educational qualifications, which does mean that there is a potential for that will drive up the banding. I guess the concern is that if that happens for health visiting, we can see a similar process ensue for school nursing, potentially other groups of professional staff such as district nurses and others. So it is something we're going to have to keep an eye on, because obviously all of this has not just a workforce implication but a financial implication for us. And we are flagging that nationally with colleagues in Welsh Government with the Director General and the Director and Chief Nursing Officer for Wales as well on this. And I know Hal's been having conversations with colleagues in Welsh Government on it as well, but it is something we're going to have. The ballot, I should say, has come back and they have voted strike action. Yeah. So we're going to be we're waiting to hear when that will be and what the extent of that will be, but it will cause obviously some disruption into the service at that point in time. Also, just to say one more point, which isn't in my report because it wasn't known at that point in time, writing the report, but we've had confirmation from Welsh Government that the first phase of the Llandryston Health Park business case, so this was the diagnostic centre, we've had funding confirmed, the first phase of the diagnostic centre build. So that's really positive news. So the FPC for that has been approved. There are some bits of work we just need to do with our neighbouring health boards on how patients are going to flow around the system, but the agreement has been reached to fund that, which is positive. You'll also know that we are partnering with an independent provider for the radiology services and endoscopy services in that facility. That procurement has concluded. We have a preferred supplier. 2 suppliers queried the process. One of which then proceeded to put in a request to the new Welsh Procurement Referral Unit or something it's called. Anyway, that is now in process. We are just waiting to hear what their assessment is. We've got colleagues from Welsh Government also just asking how long that might take, because obviously until we've got outcome of that referral, we can't finally award the contract to the preferred supplier, which of course then in turn means we can't involve that supplier in helping design the facility and finalising the design. So it is a little bit of a process that we're managing at the moment, but we hopefully get concluded relatively quickly. And the other thing I would say on NHP is the second phase, which is the orthopaedic centre, OBC was presented at the investment board at Welsh Government. There are just a few more clarification questions that have come back, which hopefully we can respond to in the next couple of weeks. But the message I had was that if we can get those things clarified, then they would be in a position to approve the OBC, which would be great as well. Because that, again, we are on quite tight timelines and all these things in terms of with suppliers and contractors. So that's really positive news. So that's all positive.
Thank you, Paul. Okay. Any questions to Paul on his report? Yes, thank you.
Yeah, thank you, Paul. It's really good update and great news about the LHP. Really welcome the estate partnership work going on. It'd be useful just to understand timescales. I'm assuming we'll come back in this year. Yeah, perfect. And I'm just going to ask about the specialist palliative care, whether we could have a briefing on that in due course when it's appropriate, just on what the pathway looks like and the new services.
Yes, obviously. So as I said in the report, we're due to start an engagement process in the next couple of weeks, which will set out the plans around palliative care, specialist palliative care, I should say, at YCC. And we will still provide palliative care in terms of general end of life care. And obviously we can brief colleagues on the board around the engagement process and how that's going to run. We're doing a lot of engagement with colleagues in Schleiss, local authority members and others on this topic. So as you know, it's been quite a topic of interest for many of our community. So yeah, we can provide a briefing.
We've got an opportunity at board briefing, haven't we? So we can do that and we can share the concentrate the engagement documentation.
That'd be great. Thank you. Thanks very much.
Any other questions? Okay, we'll note the report. Thank you, Paul. We'll move on to item 5, our governance risk insurance section. And item 5.1 is our NHS charity annual report and accounts for 2024-2025. Before I turn to Sally and to Owen, who are going to lead on the item, just to remind the board that the Health Board is the corporate trustee of the funds held on trust. And for this item, we're exercising our role as trustees of the charity. I'll ask Sally to present the annual report and accounts which are before us for approval. Thank you, Sally.
Thank you. I will hand it over to Owen, who leads on this and has done all the detailed work with our auditors. But as you say, we are the trustees of this fund, and it's important that we're acting in a different capacity when we approve these funds. But it's a good morning to do that, isn't it? Having that presentation earlier on. So if I hand over to Owen in terms of the detail of the report, and we'll come back round.
Thank you.
Thanks, Chair. Thanks, Chair. Thanks, Sally. So present the report to you. It has been to Audit and Risk Committee for comment and review previously, and they've endorsed approval of this to the board. I'll keep it brief and assume that it's been read, but just to point to a few kind of key areas. There's a couple of small, trivial misstatements which have not been corrected in the report. It does not affect the qualification of the report, and it remains an unqualified report. They relate to changes of pay award and confirmation of the audit fee for the previous year's audit, which happens after we've kind of completed the preparation of the accounts. So we adjust for them in the following year. That's happened in previous years as well. So no kind of change there. I do want to just point your view to the letter of representation, which is included in the Audit Wales report, which is in the appendix 5.1b. Within that report, it's in appendix 4. There'll be a requirement of the board to approve that letter of representation alongside the annual report and accounts, and they're signed by the chair and chief exec on letter-headed paper, which is all ready to go to be signed after approval of the report. So just to make you aware of that as well. But yeah, I just want to give thanks to Audit Wales for their kind of support in kind of getting this through to the position before we submit on the 31st of January. It's going to go to the Auditor General Wales straight after this board meeting, if approved, for signing by the Auditor General Wales, and then we'll submit it by the 31st of January along in line with the deadlines. So yeah, that's it from me.
Thanks, Owen. Before I come back to the board to see if there are any questions, Mark Jones is with us from Audit Wales. Mark, any comment from you on the report?
Thanks, Chair. No specific comments from me. The AGW's due to certify at 3 p.m. and then we return them straight away to officers. They go to the Charity Commission. It's just a case of thanking all officers, including, of course, Owen and Sally, who helped us throughout the audit, and happy to take any questions.
Thank you, Mark. Okay. Any questions to Owen or to Mark on the reports? Dilys, and thank you for, I know you've been chairing the.
Yeah,
committee, thank you.
no question really, just to confirm that the audited accounts came to Charitable Funds Committee last week and we agreed to endorse them for board approval. And I'd like to give my personal thanks to all involved in preparing the accounts and carrying out the audit.
Thanks, that's much appreciated. Patsy, thank you.
Yeah, I was just going to say it's actually the Charitable Funds Committee the accounts came to rather than the Audit Committee. I don't think they were completed by then, but thanks anyway.
Thanks, Patsy. Okay. And I think Sally's point that yeah, it's great to have this on the agenda today, following that discussion with Rob and Gemma, Natasha, Donna, and Abe earlier. I think just again shows you what we can do if we're ambitious in boosting our charitable funds, which I'm sure is something we'll be focusing on over the next couple of years. Thank you all very much. If there are no questions, our colleagues happy to approve the annual report and the accounts for 2024-25. Yes. Yeah. Thank you. Approved. Thank you very much indeed. Thank you. Thanks, Owen, and thanks to Mark. Okay, item 5.2, the board assurance framework. I'll ask Gareth just to present the update report, which has been endorsed by the executive leadership group on the 12th of January. Thank you.
Yeah, thanks, Chair. Not an awful lot in terms of update this time around. No new risks to report, no risks proposed for closure, and no changes to risk scores. But as we sort of signposted at the last meeting, there have been some updates around strategic risk control, where the detail around the control measures has been streamlined, and that's reflected and updated in the appendix to the report. As usual, updates in relation to each of the risks in red text. The board will appreciate there's been a lot of operational challenges at this time of year, which means that there isn't a substantive update to risk 1B on this occasion, but obviously that will be reflected in the next iteration of the reports. And as John's already mentioned, we are looking to use the board assurance framework more going forward, giving it more visibility and prominence in other aspects of our work, and we'll share details of that with you, at our February board development session.
Thanks, Gareth. Any questions or queries on the update report? No. Colleagues happy to approve the report? Yep. Thank you very much. Item 5.3, the board committee and advisory group highlight reports. I'll turn first to the Quality, Safety and Experience Committee and ask Carolyn as chair just to provide the update on the meeting that was held on the 18th of November, and there was one on the 20th of January.
Yes. Yeah, thank you. So again, take a paper. A few things to highlight under the alert escalate. We've discussed the special school nursing. At our more recent meeting, I think there has been a little bit of progress with that. It seems like the discussions were progressing a bit more positively, so that was good to note. Similarly, the paediatric GA list, we noted on this report positive developments, and again at the most recent meeting that seemed to be continuing, so that's really good to hear. Also, we had a fairly detailed full report on the stroke service at the most recent meeting, and that was really positive. Clearly a huge amount of work still to do, but significant progress really over the last few months, and we did want to note our thanks to everybody who's been involved in that. A huge amount of work has gone into improving the performance there, so that was really good to see. The LIMS system, which has been reported on a number of occasions, again that seemed to be slightly more positive at our most recent meeting, so I'm hoping that is continuing. And the other thing I just wanted to note was that in our March meeting we will be having a sort of wrap up of the winter pressures and the winter performance at our quality safety meeting. And in our agenda setting process, what we're trying to do now, I think, is just challenge ourselves that we are continuing to focus on primary and community care as well as secondary care, but also have more of a focus on the patient experience aspect of things. So as with all the committees, there's an awful lot to cover in that, but we do try and continually challenge to make sure we're focusing on the appropriate things. And I think that's working reasonably well. Happy to take any questions.
Thank you, Carolyn. Any questions to Carolyn? Richie, any update from you on the committee? I think it's right. No, I think Carolyn. Thank you.
So, sorry, John. Just one point clarity in terms of LIMS. Carolyn's absolutely right. So just to make the board aware, we went live with cellular pathology work in LIMS this week. Actually, it's gone really well as well. So nothing to report. So we're now on a iterative rollout period right through the next few months actually and into the summer. So good to start to be implemented.
That's what we do. So thanks to you. Thanks to Carolyn for the update. We'll note the update report. 5.3.2, the Mental Health Act Monitoring Committee, and I'll ask Kath to update the board on that meeting, which was held on the 4th of December. Thank you.
Yeah, positive escalation, which is really great news around the Mental Health Act quarterly activity report. I think we noted as a committee really good progress being made in lots of different areas, particularly around bringing down errors in the paperwork. So we just really wanted to let the board know that there was some really positive work going on there. Also just wanted to mention the power of discharge meeting that Helen chairs. We've had some really good take up, haven't we, in terms of people applying to be the associate hospital manager, and so we had a really positive meeting, I think, didn't we, Helen, at the last power of discharge.
Yeah, really positive, and we've had a good rush of applications to become the associate hospital managers, so we're in a good position in terms of numbers now. So
yes,
positive.
Yeah, and it's a really important role for us as a health board. So I'm really pleased with that. So another positive. And I think the third thing I was just going to mention was that we're still waiting for the national solution to the right care, right person transportation. So we just noted that, but at the moment everything is kind of okay. I'm looking at it, but it is something that we do need to know, that we're still waiting for that national solution. So we're keeping an eye on that. Yeah.
Thank you, Kath. That's really helpful. Any questions, Kath, on the update report? No, thank you. We'll note that. 5.3.3, the Charitable Funds Committee meeting on 21st of January. Thank you, Dennis. I'll hand over to you for this one.
Yeah, thank you, Chair. Only one item in the alert, and that's the agreement of a new investment policy, which was approved at the committee. This will mean that there will be engagement with procurement for tendering for the future investment manager contract based on the perimeters of the new investment policy. I would bring your attention to one item on the advice section, and that was the presentation on the charity branding work that's been done so far. A lot of work has gone into this, including engagement and consultation, little bit of further work, and it'll be coming back to the March meeting, so hopefully we'll have something to bring forward from there.
Much appreciated. Any questions to Dennis on the Charitable Funds Committee? No. Okay, thank you. We'll note that report as well. We'll move on to item 6 under delivering our plan and performance dashboard. Just say before I take colleagues, what we'll do as per usual is I'll bring in the different executive colleagues for those different aspects of the performance report before I throw it open to the board for questions. So I'll hand over to Claire first to introduce it. Thank you, Claire.
Thank you. Thanks. And following feedback from board members and the audit findings, this is an adjusted IPR, so has been already through ODC, and it's an interim really ahead of any further iterations for 26-27. There's a 25% reduction in the number of pages, so taking that as a win. But the key changes are that we've included a narrative summary of the key indicators, so pulling out the risks and actions and the forecast against those core domains of accessibility, safety, confidence and health. So that's on pages 2 to 4. We've retained the Cabinet Secretary's priority measures on page 5 and the SPC approach to that. I am noting that for some reason this month it is challenging to read that on admin control, so it has been possible to read it on admin control before, so I don't understand why that is. Apologies for that. And then we have retained the detail of all the performance metrics in Appendix 1, so page 18 onwards, for those who want to drill into that, and we've included and consolidated the benchmarking data. So Appendix 2, page 22 shows us our position against those metrics against other health boards in Wales. So I won't repeat what Chief Executive said in his report, but just to note that planned care is on track, that diagnostics were at the last board meeting going in the wrong direction, but those are now back on track and predicted to deliver. We know about the urgent care handover improvements and the need to keep our eye on the mitigation of the risk around 12-hour waits. We've got positive performance in CAMS. Adult assessments have deteriorated, but with an improvement plan. And in quality, the nationally reportable incidents and complaints continues to go in the right direction, but with a key concern around the healthcare acquired associated infections. Population health. I just thought we ought to try out what the problems for childhood immunisations, aren't we, in Wales? And I just haven't necessarily said that. And whilst we're not where we want to be on adult flu vaccination, we know the huge amount of work that's been done in terms of the community engagement and improvement around that. So turnover and appraisal going absolutely in the right direction. But I know Howell wants to talk about the work and intensive work that's going on around sickness right across the whole organisation. Summary.
Thank you, Claire. Really helpful. I'm going to hand over to Gethin to deal with the operational section of the report. Before doing so, can I just say thanks to the team for the way you captured the key highlights in the document, particularly around risks and actions. So I think again it just brings things out, and I think that is an incredibly helpful way of just bringing some of those key challenges, but also reminding us of the enormity of the work that is going on day by day, not just to mitigate the risk, but also to seek improvement. Thank you.
Yeah, I won't say very much. Claire's covered the vast majority of the points. Just in terms of diagnostics, just to provide board some assurance that the numbers for January continue to fall, which is really positive. So we remain on track around diagnostics. We have got certain modalities, additional capacity commencing this month, particularly around our neurophysiology services, which is good. And in terms of our imaging, as board will be aware, we will be implementing the new RISP, which is the informatics system that sits behind the way in which we record and share images at mid-March. So we're aiming to actually get our waiting time for diagnostic imaging down to around 4 weeks prior to that go live, to just build into that capacity for risk. So that is being supported by colleagues in Welsh Government who have provided some additional funds for us across a range of modalities. What we aren't seeing, but other health boards are seeing, is actually their pathway 2 cohorts, that's the diagnostic cohort, increase on the back of the additional outpatient activity. So that is positive. Again, on the outpatient position, we continue to see a real reduction in those volumes with the support from the nationally procured programme. Other health boards have not been able to utilise their full allocation, and we have taken that on ourselves. So again, really trying to build that headroom in our waiting time capacity for April. So that is all. That was all I'm going to raise.
Thank you, Gethin. If members can hold off on the questions until we get through the quality section of the report as well. And before doing so, there's quite a lot of operational detail here, which I know that Rich, Don, Lauren, and Philippa want to touch on. So, Richie, I'll come to you next. Thank you.
Thanks very much. And just to kind of follow on from where Claire has placed us in this report, I think on the IPC, absolutely, there's ongoing focus and attention there. It's particularly live at the moment when we look at our respiratory-borne infections as well as the norovirus. I think that what I kind of want to say in this space is that there's also behind that a strengthened focus and attention around IPC in terms of the resource now sitting within our community setting, as well as then some of the strategies and initiatives that are being implemented across the acute setting. We need to give that some time to see the results of that and to understand how that pans out. That work continues, and we obviously report through the Quality Safety Exec Committee as well as IQPD, and we'll continue to make sure we've got a focus on that. But clearly, that there are instances there that we're reporting. I think the other is linked to this as well. Again, a focus within the Quality, Safety and Experience Committee is pressure damage. You can see there that the number of incidents being the highest that are nationally reportable. Some brilliant work in there in that space. I think where we are now, though, is understanding the impact of that and how that can positively demonstrate a reduction in those numbers. The work within our concerns team and the wider care groups continues, maintaining our 30 working day performance. There's a lot sitting under that we are working through in terms of ensuring that our patients and their family members get timely response. We do not always get it right, that's clear, but what we need to do is focus on how we can continue to do that, where we're doing well, understand why we're doing well, and how we can continue on that path. I think the other thing I would say, just in relation to IPC more generally, is the E. coli rates. But again, I think my narrative and briefing to you around the current live situation, and particularly around respiratory-borne infections, is similar to then E. coli and the initiatives we're putting forward. We now need to understand how those play out over the course of the next few months, and we started to implement some improvement science into this field as well. I'll probably pause there, but happy to take any questions afterwards. Thank you, Richie. Don, thanks.
I'm going to keep this very brief indeed, as you've got the data in front of you, and I'm happy to answer any questions on it at all. But as you can see, our crude mortality rate is coming down, certainly the lowest it has been now for 2 years, which is encouraging. And the mortality board is working really well at identifying some of the areas we need to get some deep dives going. So I'm hoping to, it may not be the next book, but the one after that is to bring you a different set of data that will summarise this in a much more clearer way for you to see.
Thanks. Lauren, thank you.
Thank you. So an update from a couple of the professions. Within psychological therapies, the waiting list validation's been completed now, and additional hours being worked by the team where they can to help address the backlog, and those new groups, so group therapy starting at the end of the month. So the plan is to have 150 people starting therapy within the next 10 weeks. So that'll have a positive impact on the waits. Within stroke, as Carolyn said, there was a detailed update that went to Quality, Safety, Experience Committee, focusing on performance, a particular focus on the AHP staffing, and the impact on the progress with the transformation programme, which is positive. And then there was also included in there a detailed paper on the impact of the emergency moves around stroke to give some assurance to the committee. And then just to say, the early supported discharge team in stroke have been doing some targeted work within YCR, so the stroke rehab ward in Ysbyty and Rhondda, and we're seeing some really positive impact there. So they're going in and really encouraging and challenging the ward team to really think about discharge home at the earliest possible point. So they're having really early communications with family members to help prep the home for rehab at home at the earliest point. So while ESD don't need to be based on the ward, we're seeing the impact of that culture shift happening there. And then the plan is for that team to do something similar within the Royal Glamorgan, so we can try and increase the number of people going from the Glam home for their rehab at the earliest opportunity. So that's positive. And then in terms of diagnostic weights, you can see they're heading in the right direction. There's been a focus on sonography over the previous few months, and increasing their capacity. And there's reference in the paper about the work that we've been doing with National Imaging Academy Wales. So they've been running training lists that will help tackle the future workforce supply in terms of sonography, but they're also taking from our waiting list. So it's a win-win, which is positive. Gethin's talked about wrist, Stu's talked about limbs. That's everything. Thank you.
Excellent. Philip, thank you.
Thank you. Claire's raised the fact that we are performing relatively well in terms of childhood immunisations. That should be taken in the context. So there we're speaking not only about flu, but also about measles, mumps, and rubella immunisation. You'll have seen that the UK has lost its elimination status for measles, right? And so whilst we are doing well, we can't rest on our laurels. We're in a situation now where we will have imported cases. So keeping those immunisation rates high means that we can't have further transmission, right? So we are doing well, but we're laser focused on the fact that we can't rest on that. Again, in terms of winter vaccinations, we are at or exceeding Welsh averages. But again, there's still huge scope for improvement. I really want to raise attention to the work that the comms team have done in terms of the winter campaign. I think it's excellent. We have seen an increase as a consequence. Obviously, it's early days in terms of plotting that, but we'll keep going. One thing, so thanks very much to the comms team. Again, thanks to Hal's team as well in terms of staff vaccinations. Again, we are top of the charts in Wales. We are #1 in Wales for staff vaccinations. What's problematic is it's still only 50% of patient-facing staff, right? And that is a patient safety and quality issue. And I raised it yesterday with Welsh Gov. We had a health protection meeting. It needs a national effort, really, in terms of increasing levels of staff vaccination uptake. But lots is going on. And finally, keeping us focused on what is effective in terms of preventing ill health. We are far exceeding our target for smoking cessation. And that is the third year of year-on-year improvement that we've seen. But it's still not enough to get us to where we want to be. So the national target is 5% by 2030. There's clearly a lot of activity that needs to be done to get CTM residents to that point. However, we have increased the capacity team to achieve that. So that's me. Thanks, Chair.
Thanks for that. And for the workforce section of the report, I'll come to Howell. Thank you.
Sure, thank you. So again, Claire's already mentioned turnover, which remains pretty stable at just about 5%, which if you look at the beginning of the graph there, we were at a high of around just shy of 13% a couple of years back. So that's a huge change, and that's had a massive impact on our recruitment and indeed our vacancy levels. The very, very slow, stubborn improvement in PADR compliance and level 1 compliance continues. So we're at 71.5% PADR compliance, which is the highest we've been again for a number of years. But we're still just shy of the 85% target. For level 1 Stataman, we're 81.8, so just 3.2% shy of the 85% target. Now, some great work happening there when you consider how much pressure there is in the system. I do just want to highlight some of the work that's been done in facilities of late on a number of those metrics. So they've seen significant increase in PADR compliance from 57% to 79% in a couple of months. Just shows what can be done with focused leadership. And also they've seen an improvement in their level 1 compliance and Stataman training, and are doing some really good work on their long-standing sickness cases as well. I remain concerned about sickness absence. So you'll notice from the graph that our usual seasonal variation, which usually kicks in around about kind of December time, has probably started a little bit earlier this year. We are tracking well above pre-pandemic levels of sickness absence. So there's lots of focused work happening on that at the moment. I had a couple of conversations with colleagues around the table the last few days, just about a bit of concern about whether that's ramping up as quickly as I'd like it to. So some additional extraordinary actions have been agreed in my team just to refocus some of what we do around just making it easier for people, frankly, to do the things that we need to do in terms of return to work compliance, prompts within the policy, and indeed regular contact and management of long-term sick cases when things are busy. So just making it easy for people to do those right things. So we'll continue to do that and track progress on the comprehensive plan that we got through ODC.
Okay, thank you. Thanks to colleagues for the updates on the different sections of the report. Questions or comments from board members? Patsy, thank you.
Yeah, thanks very much. We did discuss this at length at ODC, so I'm not going to go over every point that I made, but one point I think is important. We need to understand the WAST performance for our resident population. We don't see that now in this report, or indeed in the ambulance handover report. We see the massive improvement in handover. We see the consequences of that, and I'm not saying that's that the improvement in handover is a bad thing. It isn't, but it's not without consequence. So we need to understand if the WAST performance is improving for our resident population.
Thanks, Patsy. I'll bring Gethin in on that point, and board will know I've raised this point a few times in the last couple of months.
So on the first point that Patsy raised, and as we agreed in ODC, we'll make sure that the WAST graphs go back into the performance report. They were lost in this iteration, so apologies, and we'll make that. Equally at ODC, and I'll mention it on the paper, we did take a paper to ODC looking at are we able to yet see any correlation between improved response times in our community on the back of a significant reduction, and the data was not wasn't massively clear that we are seeing a significant improvement. There has been an improvement, but not a significant improvement in response times. And clearly part of that is around WAST as an all Wales service using their resource across the patch. And so seeing more of our the CTM resource potentially being used due to support delays in other health boards, and some of our neighbouring health boards haven't seen the same improvement in handovers. So that, but we'll bring all of that back because there was more scrutiny we needed to do on the data that went to ODC. So we'll bring that back to a future.
Thanks, Kevin. I appreciate that, Richard.
Yeah, thanks very much. And I suppose in supplementary or complement to that, I've been commissioned by the Quality Safety Experience Committee to look at what we can do in relation to quality and safety. So I'm in discussions with the Executive Director of Nursing for WAST to understand of what they're producing in and around our population and safety and quality, of how we can incorporate that as part of our reporting. So I think those there should complement each other in what Patsy's asking.
I think it's really important because, you know, if the public were looking at this data that we publish and that we report on, they would wonder what we're doing about it. Yet actually, having done a huge amount of work to improve handover times and to release ambulances from the forecourt and to improve the position that they were in some time ago, where they were losing quite a large number of hours, they've now regained that time, yet their performance is largely out with our control. So yet we're the ones having to report it. So it does seem a little unfair. But we do need to see this, and I'm really grateful that we are looking at this. So I think if we can return to this at some point, because I did say some months ago that I think the board was content to allow time in order to see whether this had filtered through to an improvement in response times by the ambulance service. But if it hasn't, then something's clearly going wrong. And it means our population is at a disadvantage if the response times are not improving. So I'm really grateful to the team for that. Thank you, Patsy. Okay, any other? Thank you.
Yeah, thank you. Yeah, thank you, Chair. I think it was really good to have that summary, and so really welcome the paper. The healthy weight management is the one I couldn't find. I'm just wondering whether that would come under the population health metrics. And obviously we were looking at the children's weight management service, weren't we? As well. So I just wondered whether we thought we could bring that back into here.
I think Rachel's going to come up with a similar question next as well.
Yes.
So there's, I mean, inevitably we can't put everything in the report, but
No.
It's how we develop it going forward to there's the things that we need. And I'd be happy to pick up a conversation about, well, what population health metrics, because obviously they're published at different times as well.
And also, frankly, the frequency of reporting of things, some of these population health metrics. So bringing something every quarter or every month, every 2 months isn't going to really show any change, is it? Because they're not metrics that shift that quickly. So I guess there's something, maybe some of the areas you were responsible for, Philip, maybe a chat with Claire and Rachel and Kath outside of here about how do we present them, but in a way that is meaningful and gives clarity about what is happening, because otherwise there's a risk that they're not moving.
Claire, on this before I've been mentioned.
It's really helpful, and thank you for the feedback. I think I did say it's an interim, and what we need to do is and actually I've never worked anywhere where the IPR's done everything for everybody. Like there's always a kind of push-pull between I want to see everything as opposed to and so I think it does go to the points that were being made earlier about the board governance and what is managed at what level. So the ODC and ESEC have those conversations, but being really clear about that. And we can use that as an opportunity to say, well, some of these metrics will come, it will come less frequently, but the ones you'll see every board meeting are.
Yeah.
Rachel.
Yeah, thank you, and thanks to Claire for all of the information and for reducing the ODC papers by 25%. That was wonderful. So just want to make a note of the improvements in the cancer pathway, performance. That's excellent news, and also the news that we had about the diabetes improvement, which was the thing that I thought, oh, that was in the ODC stuff, but not in here. And because it's a positive thing, I just wanted to make a note of that. Just a question around adult mental health assessments, Claire. You mentioned that that's not performing as well as the CAM stuff, and that there's an improvement plan. I just wanted to check in, when are we likely to hear more about that, and what is the process for
question? They're working through a backlog, so that's the intention. Will it it's back up again? I need to get back and get the detail or get the
okay, but probably coming to an ODC.
We can bring a update.
Lovely, thank you. And again, a question of probably Malusha actually, in terms of the POCD stuff around the discharge app. I'm sorry if I missed this at the ODC last week, if it was in that. There's a mention of access to other partners to the app. I just wanted to check that other partners included the third sector partners that is involved in discharge for older people, and not just local authority, because the third sector do play a really they play a role in that discharge planning, and often, certainly from my experience when I worked at Age Connect, some of the frustration was around the fact that we didn't, as a third sector partner, have access to some of the technology that would have allowed us to be genuinely part of the whole system. So I just wanted to check.
I don't know.
Okay.
Is the answer. I will check. I suspect there will be IG challenges, but
Yes.
I will confirm that.
Yeah, lovely. Thank you, Claire. Thanks, Claire.
Thank you. That's very short. Okay. Any other questions on the report? What's anticipating at 24?
That was my laptop, and I have no idea.
Brilliant time. Okay, right. Thanks to the team for the updates. Thank you for the way, again, it's been captured. That's been incredibly helpful, and I'm sure we'll return to much of this as well over the next few months. So we'll note the report. What I'm going to propose to do now is, before we move over to item 6.1.1, which is the ambulance handover and discharge process update from Get-In, I'm proposing we'll take a break for 10-15 minutes, and we'll return by 11:15. Yeah, right.